So I was coming to the fact that I wanted to tell you about collaterals. So let's say that patient came to you and said that, hey, doc, yes, I don't want to put a stent in me. I have an 80% blockage. I failed my stress test, not in a big way, in a little way. I want medical management. Perfectly okay. Now, a couple of things I want you to understand. When you flunk a stress test, it's not just plus or minus, which many people think it is. It's not. So let's say only a small portion of your heart was not getting enough blood supply. Yes, you failed your stress test, but is that catastrophic? Can I do medical management on you? Can I say to you, you know what, you have a blockage, but you want medical management only and you want to do lifestyle changes and prevention? I'll let you do it. But let's say you do a stress test and the entire front of your heart gets wiped out on that stress test. And then you come and tell me that you want to do medical management. I want to say no, because that thing is causing so much ischemia in you. You may not be feeling it, but it's going to kill you. For example, a widowmaker, right? A widowmaker is at the beginning of the artery. And if that's causing a problem, it's causing so much ischemia, so much lack of circulation. There's no medical management for that. So yes, the answer is that some patients want medical management. You can do it. You got to look at the ischemic burden, as I call it. What is the ischemic burden? It's mild. How much muscle is in jeopardy? A small amount. So let's say that he shuts it off in that area. He's going to get a tiny heart attack. He'll survive it and he'll move on. So there are cases where we do medical management. But when we do that, we do a lot of prevention and we want to build collaterals. So that's an important thing. So let's say that you do have an 80% blockage and you want to do medical management. You need to build up collaterals. So you work very hard on your prevention program, exercise program, which we can talk about later on, and EECP and treatments like that increase your collateral blood flow. Because at the end of the day, when a plaque ruptures and shuts down the artery, how much damage you're going to get at the bottom depends on your collateral blood flow. If you have collaterals, the damage will be limited. If you don't have any collateral, so people say that, oh yeah, this 56-year-old guy who shut off his LAD, he gets a massive heart attack. The same artery in an 80-year-old doesn't cause much. I mean, yes, he's still getting a heart attack, but he's likely to survive it because the 80-year-old has more collaterals over time than the 56-year-old. That's why a heart attack in a young patient is catastrophic. Most of the time, they don't even make it to the hospital. Why don't they make it to the hospital? Why do heart attacks don't make it to the hospital? 50% of heart attacks never make it to the hospital. The artery shuts down, they start getting chest pain, and the EKG source changes. They die in the ambulance or they die at home. Of what? They're not dying of the heart just getting so much damage. They die of an arrhythmia. That is why as soon as you're getting a heart attack, you need to be monitored, get that ambulance in, because if your heart stops beating, you need a shock. So 50% of the patients, they die of an arrhythmia. So now you're seeing that I've introduced a whole new, it's not just the pump. It's not just the blood supply to your muscle that gives you the pump, right? If muscle dies, your pump is going to get weak and then you're going to get congestive heart failure. But when you get sudden abrupt cessation of blood flow, you are going to get an arrhythmia. And that's something that people just don't understand, arrhythmia. And I do want to say something about an arrhythmia here, because when patients have multiple blockages in all the arteries, a lot of plaques, and they died at home suddenly, then autopsies were done on those patients. And we go inside and we take a look. We found that at least 60% of the times, there was no ruptured plaque. And we say that, oh my gosh, all the arteries are open, but they're all severely diseased. So what did he die of? He died of an arrhythmia. When sufficient mass of muscle becomes ischemic, you get an arrhythmia. And you die before there's a chance for necrosis. This is important. Necrosis means death of the muscle. Artery shuts down, you've got 4 hours to get that blood flow going again. Otherwise, a substantial amount of that muscle is going to be dead. In the meantime, you're at risk of arrhythmia. But the more the muscle, greater risk of arrhythmia. That's why if you have a widowmaker, that's it. You just have to get revascularization. Why? Because you are at risk of an arrhythmia. You could be walking across the house and you'll just keel over and die of an arrhythmia. So arrhythmias are very, very important. Blood supply to the heart muscle is important. The electrical system is in the heart muscle. So don't think that they're not going to get spared. They are going to go into an arrhythmia. So that is why we are very, 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 if you have a large amount. So you see, the point here is that you need to individualize your care. Yeah, you flunked your stress test. How? How much muscle was in jeopardy? You flunked it. In the old days, we would just do a regular stress test. You run on the treadmill, you look at the EKG. And the EKG is either going to be positive or negative. But it doesn't tell you how much muscle is ischemic. Now, we have two additional types of stress tests that we do. One is a regular nuclear stress test, and one's a PET stress test. These are nuclear stress tests. So what you do is, in addition to looking at the EKG portion, you're looking at the distribution of the blood flow. So my heart is like a balloon. My front is not getting enough blood supply, or my bottom or the back part of the heart. And you can actually quantitate, you can actually see, even visually, how much of the heart muscle is being deprived of blood flow when you're exercising. So if it's a small amount, okay, it's a branch vessel disease. So when you angiogram that patient, you'll find that the distal branch is blocked or narrowed. But if it's the beginning of the artery or the widowmaker, which is the left main, then you'll see that the entire front is abnormal. So it's not just black and white. You've got to thoughtfully look at the stress test as well. And then you do what is a risk assessment for that patient. Is this patient a high risk or low risk? And you got to give that. So that is important. And then, of course, the whole prevention program is important. But just the cardiology part of it has really evolved, and we do have this technology. We do have it. It's just sometimes not adequately used, or there's not enough thinking that goes into the stress test interpretation. It's not black and white. So I wanted to stress that, because that's really important. Because you're right. If somebody comes to me, he's asymptomatic, he's got a coronary calcium score that's moderate, his stress test is positive, but a very small amount of it is abnormal. And let's say he wants to go for a hip replacement. What am I going to do? No, you cannot go for hip replacement. You need perfect perfusion in your heart muscle. No, I'm going to clear him for a hip replacement. I'll send him there, but I'm going to do a lifestyle change. And I see that a small portion of his heart is not getting enough blood supply. He can still actually go for surgery, and he can still live a pretty good life. We got to do the prevention program, because the risk of arrhythmia is low. Even if that artery shuts down, he's not going to go into cardiogenic shock. Cardiogenic shock, meaning a whole bunch of muscle just died, and his heart is now doing this instead of doing this. See? So, so where is the plaque? Which portion of the artery is the plaque? Is the plaque in the beginning of the artery, the middle, or the end of the artery? Is it in a branch that's causing your problem, or is it in the left main? All these things are important considerations when you're interpreting a stress test or an angiogram for that matter. So, and the decision about stenting versus bypass surgery is a very important one as well. Do I send patients for bypass? Of course I do. A lot? No, hardly. But I do. When I do because they've either got left main or they've got a blockage that is serious and I can't fix it because it's at a branch. So if I fix one branch, the other one will shut down. This is a critical decision. So those types of patients where they have multiple branch disease, which I cannot stent, and he has a lot of ischemia, his ischemic burden is high, those patients need surgical revascularization, where you're bypassing the plaque, you're bypassing the blockage. So these are the kind of critical decisions that we've learned to make over the years, because we used to send a lot more patients for bypass surgery, and we send much less patients for bypass surgery nowadays.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
A lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing. And there are ways to find this out now. We have the technology. It's just not being done. And those who